I'd like to appreciate the efforts, sincere efforts by Professor Wesam Ismail. This is the 10th day, so 10 days, 20 hours educational activities. It is very marvelous efforts and sincerity. يعني يعجز اللسان يعني عن انه express appreciation والgratitude للefforts اللي حضرتك بتعمليه. So today it is very interesting and very complicated. We don't like diagnosis of thrombotic microangiopathy at all because there are many dilemmas. And today, I think Professor Wesam will give us a hint about thrombotic microangiopathy, and she will clarify this dilemma. Professor Wesam, تفضل.
Thank you very much, Dr. Hussein, and it's always a pleasure to participate. And I hope that I'm going to, to be able to clear this dilemma. But yes, TMA is a dilemma, honestly. So we will try to go through it, hopefully to try to correct شوية معاريف قديمة موجودة عندنا, and that we try to look at thrombotic microangiopathy from a different concept. Maybe this will help to solve the dilemma we are in, but I can't promise that we're going to solve this dilemma 100%. Okay, this is a demonstration case. This was a 12-year-old male who presented in June 2013 with vomiting, fatigue, intermittent fever, and oliguria for 4 days. This kid is known to have metastasizing colonic adenocarcinoma since 2 years. His metastasis has reached liver and peritoneum. Patient was on chemotherapy in 57 and had received already his last cycle. And he had a query family history of nephrotic syndrome. It wasn't confirmed. So this male, after finishing his last cycle of chemotherapy, presented with fatigue, intermittent fever, and oliguria for 4 days. Of course, he was underbuilt, malnourished. He's a malignant patient. He had oral ulcers, which were considered a query monoliasis. His temperature was 38.4. Heart and chest examination unremarkable, and he had revealed tender hepatomegaly because of the metastasis. Anemic, which is expected, but his platelets count was 60,000, which was, although his TLC was 11,000, so was not really pancytopenic. His total bilirubin was 2, indirect 1.2. This was liver enzymes high. And his serum creatinine was 6.5. Remember that he is only 12 years old. And he had 24 hours protein, 2 grams per day. His kidneys were normal sized, so a renal biopsy was performed. Of course, in such scenario, the differential diagnosis is really wide. Now, he had this query history of nephrotic syndrome, and when they found that there is proteinuria, then they considered a glomerular disease. On the other hand, he's in acute renal failure, which could have been a complication from the chemotherapy he had already received. He had evidence of infection. He was feverish. He had oral ulcers. So we had a different, more than one differential diagnosis. Let me show you his biopsy. Now, this was his glomeruli. And this is a glomerulus, this is a trichrome stain, and this very bright, nice pink thrombi are fibrin thrombi in the capillary lumina. So this is a thrombotic microangiopathy in the glomeruli, and also were in his blood vessels, and this attributed for his high serum creatinine. But he also had a suppurative interstitial nephritis. Do you see all of these are neutrophilic costs within the tubules? So this kid has 2 diagnoses, had thrombotic microangiopathy in his glomeruli and suppurative interstitial nephritis in his interstitium. This is another glomerulus, and you can see the extent of red cell fragmentation. This is what we call red cell fragmentation. So these are fragmented red blood cells, extensive congestion, fibrin thrombi in the hilar arteriole. Look at the rest of the arteriole here, and look at the thrombus. Look at the extent of red cells, fragmented red cells. This is a classic what you call TMA. Another arteriole, and you can see again the thrombi and the red cell fragmentation. His immunoperoxidase was negative, so his diagnosis was a thrombotic microangiopathy associated with acute suppurative interstitial nephritis. because thrombotic microangiopathy is not going to cause an acute suppurative interstitial nephritis. Did we solve the dilemma? Did we know what's wrong with this kid? What is the cause of the thrombotic microangiopathy in this patient?
دكتور وسام.
Would you consider this hemolytic uremic? نعم. الصوت راح؟
لا الصوت كويس. بس العمل بايوبسي في بليتلت 60,000 ده فيري بريف يعني. يعني فيري ديفيكولت. صح هو مكتوب في الكتب ان لو تحت 50,000 يبقى كونترا انديكيتد، لكن وناس ثانيه بتقول 80، لكن احنا اصلا لما بيبقى تحت ال 100,000 بنبقى قلقانين جدا وحاطين ايدينا على قلبنا. يعني يمكن حتى بنعمل بليدنج تايم لو النورمال، لو العيان الكرياتين عالي والبليتلت كاونت نورمال بنعمل بليدنج تايم كمان مع الاي ان ار، لان بنبقى خايفين من بليتلت ديسفانكشن. فبرضه بايوبسي في بليتلت 60,000 ما اعرفش، برضه ده كان فيري بريف قوي، وكان لاكي ان ما حصلش بليدنج.
يمكن صلحوه قبل البيوبسي وكانوا مديني الداتا اللي قبلها.
تمام.
يعني I don't know. The fact is ان this was not a remarkable finding for them علشان خاطر البروتونوريا والكويري هيستوري اوف نفروتيك سندروم، عشان خاطر كان واخد مالجنسي وكان واخد كيموثيرابي. ما حدش قوي فكر، يعني ما حدش فكر ان this was a presenting feature actually of the problem ان هو كان thrombocytopenic، لان هو he ended up ان هو بقى عنده thrombotic microangiopathy.
تمام.
The question was thrombotic microangiopathy دي ليه؟ هل دي hemolytic uremic syndrome as you like to call it? Is this because of the malignancy? Is it because of the infection? Or is it drug induced because of the chemotherapy? Is the cause detectable from the biopsy findings? Can the biopsy tell you which one of these is it? Do we have any idea about the prognosis, the renal prognosis? These questions are what I'm going to hopefully discuss within this talk. اتفضل دكتور حسين.
يعني لو انا هاجب على السؤال الثاني، الباثولوجي هل هيقول لي الايتيولوجي؟ ما اعتقدش. يبقى ذا كوز ديتكتبل فروم بايوبسي، الاجابه هتبقى بالنسبه لي يعني لغايه ما نسمع نو. فالحاجه الثانيه الهيستوري اوف مالجنسي ده مهم جدا. يعني حتى لو هو العيان عنده مالجنسي والايتيولوجي والثرومبوتيك مايكروانجيوباثي ريليتد لاذر ايتيولوجي او لدراجز يوزد، مش هتفرق معايا كتير قوي في المانجمنت. فما اعرفش لو حد عاوز يعني من الساده الحضور يعني يعلق برضه في النقطه دي، بحيث ندي فرصه كده للدكتور وسام تاخد ريست لغايه ما الدكتور عصام معانا ولا ايه؟ الدكتور عصام معانا؟ طيب الدكتور سعيد تحب تعلق؟
ايوه مساء الخير يا دكتور وسام. مساء الخير يا دكتور
مساء النور دكتور سعيد.
الله يخلي حضرتك. لو تتذكري حضرتك انا المره اللي فاتت سالت هل من البيوبسي ممكن افرق ما بين الايتيولوجي بتاع التي ام اي ولا لا؟ حضرتك قلت لي وارد نقولها في التي ام اي سيجن او كده. بس خلينا من السؤال ده عشان الدكتور حسين شويه مش مستريح للقصه ديت.
لا هي ممكن يبقى في حاجات
يعني
زي اللوبس مثلا، لو في لوبس ستيجماتا، لو في حاجه، لكن على الاطلاق هيبقى صعب ان الباثولوجي يديماركت.
يعني هو الاجابه، لا الاجابه الحقيقه زي ما الدكتور حسين قال، الاجابه في الكيس دي الاجابه از نو.
يس اوكي.
بالنسبه
للدرجه
شكرا
بالظبط.
حقيقي
ممكن نعرف الميديكيشن ايه اللي خدها بالظبط يا دكتور؟
لا الحقيقه ما اعرفش اكتر من هو اخذ كيمو لميتاستاتيك ادينوكارسينوما.
تمام.
وممكن يكون كله على بعضه يعني.
تمام.
يعني برضه ممكن يكون حاجه بريسبتيتد، حاجه
مالتي فاكتوريال يعني.
احتمال برضه. هو الفكره في الكيس دي انا I always like to start with it عشان to show you ان thrombotic microangiopathy is not a disease. This is what we have to start with. And when you get a diagnosis of thrombotic microangiopathy, you don't have a diagnosis. You still don't have a diagnosis. You don't have a disease yet. You need to look behind it to find what is the disease. So the term thrombotic microangiopathy was first introduced in 1952, and it defined a lesion of vessel wall thickening, mainly arterioles or capillaries, with swelling and detachment of the endothelial cell from the basement membrane, accumulation of fluffy material in the subendothelial space. This is an ultrastructural finding that we get intraluminal platelet thrombosis and partial or complete obstruction of the vessel lumina. Number number 3 and 4 is a plus or minus, meaning that although it's included in the definition of thrombotic microangiopathy, you don't have to have thrombi to diagnose thrombotic microangiopathy. So TMA, or the term thrombotic microangiopathy, is a pattern of disease. This is a histopathological, a morphological term. It's a description. It defines that we have glomerular, arteriolar, or interlobular arteries, since we're speaking at the level of the renal biopsy, lesions, endothelial lesions, and it is characterized by a patchy distribution. It's not usually diffuse. These lesions has a very variable morphological patterns, as I'm going to show you, and they differ from being acute lesions to chronic lesions. Typically, your typical patient is going to present with thrombocytopenia, with MAHA, microangiopathic hemolytic anemia, organ injury, frequently AKI, since the kidney is a target for TMA. However, these symptoms will depend on the organ primarily involved, so they can vary considerably from mild to severe. It's also not always associated with overt laboratory findings, raising the question that you can have an organ-limited thrombotic microangiopathy. So you can have thrombotic microangiopathy in an organ without these, without having a microangiopathic hemolytic anemia, without having thrombocytopenia, without having schistocytes in the peripheral blood. And we call this organ limited. عرفناها منين؟ عرفناها من transplant. Again, دي حاجة من الحاجات اللي transplantation علمها لنا. ما كناش نعرف قبل كده that we can have an organ limited or a renal limited form of TMA. So again, the lack of presence of thrombocytopenia or schistocytes in the peripheral blood is not an argument against the presence of thrombotic microangiopathy. This is a pattern or a morphology or a lesion which is associated with significant morbidity and mortality. These patients, when they are not recognized early, they can lose their kidneys. The pathological features we see in the kidney, which are the diagnostic features, will depend upon the type of injury, the degree of injury, and the stage, whether we have it early versus late. Usually in the kidney, whether it's a native or transplant, both gives the same pattern. It doesn't make a difference. You have interlobular arteries, afferent arterioles, and glomerular capillaries are typically affected. And as I said, the pathological features can be divided into acute and chronic lesions. And these acute and chronic lesions can be glomerular only, which is one of the most difficult diagnoses. Could be arteriolar or arterial dominant, or could be mixed. Then you have glomerular and arteriolar and arterial/arterial lesions. So it does not have to involve the glomeruli and the arterioles and the arteries. Sometimes the glomeruli are spared, and you have mainly the dominant lesions or the dominant activity are in the arterioles and the arterial compartment, or it's only in the glomerular compartment and there are no lesions in the arterioles, or it's all of it, glomerular and arteriolar lesions. This pattern will not distinguish between the multiple disease entities associated with thrombotic microangiopathy. It can only suggest, meaning if I have a dominant glomerular injury with only endotheliosis and endothelial swelling, then this is probably a preeclamptic injury caused by preeclampsia. When we have a dominant arteriolar and arterial dominant lesion, then this is probably hypertension related, and so on. So yes, we can guide sometimes in some of the lesions, but it's only a suggestion. I cannot tell you for sure that this thrombotic microangiopathy is caused by such and such. In the transplant setting, the situation is different, as I'm going to discuss. So let's look at the morphology. What is the glomerular lesions? I want you to look at this glomerulus. This glomerulus looks like occluded. All these capillary lumina are actually occluded by what we call endothelial swelling. So we get all of this in swollen endothelium some red blood cells fragmented here. Again here, this is the main lesion you get in thrombotic microangiopathy. And this is TMA, without thrombosis, without congestion, without extensive red cell fragmentation. This is still thrombotic microangiopathy just by the extensive endothelial swelling. Let me show you. Did you see this? Extensive endothelial swelling. Almost looks like you have foam cells inside the capillary lumina. Look at the arteriole. The arteriole is already thickened. So this is again thrombotic microangiopathy. And as you can see, there are no thrombosis, no inflammation, and no red blood cells. So this extensive endothelial swelling is one of the landmarks of thrombotic microangiopathy, and it's a very acute early stage of the disease. Then by another thing, you can find another glomeruli where you start to have these small, you start to have inflammation, mainly neutrophils, again with the endothelial swelling and few red blood cells, as you can see here. Or you can have extensive red cell fragmentation. All of these orange color are the red blood cells, the fragmented red blood cells. And this is an engorged, congested, markedly congested glomerulus. And as you can see here, for example, this glomerulus does not have endothelial swelling and does not have thrombosis. It only has congestion and red cell fragmentation. Again, this is thrombotic microangiopathy. Look at this one. Here you have a little swelling, another fibrin thrombus here, and look at the arteriole. This is a fibrin thrombus and a lot of fragmented red blood cells. The red blood cell fragmentation can also be noted in the interstitium and within the tubular lumina. You don't get red blood cell costs, you get fragmented red blood cells within the tubules. This is different. There are a difference between red blood cell costs and when you get these fragmented red blood cells inside the tubular lumina. And you get occasional thrombus formation. And as I said, this is not a must for the diagnosis. I don't have to see a thrombus to diagnose thrombotic microangiopathy, up to the degree that it's being under discussion for a few years now that we change the terminology and we drop the term thrombotic from thrombotic microangiopathy, and that it just changes into only microangiopathy. So this stresses the fact that you don't really need to find a thrombus. This is why some of the patients are not thrombocytopenic. You don't get these marked platelet consumption because they don't form thrombi. So this is a large hilar thrombus, as you can see here, again in a glomerulus with all of this congestion and endothelial swelling. Look at this, another glomerulus with a TMA. I'm trying to show you the full spectrum of thrombotic microangiopathy and to highlight the fact that they are not always that easy to spot. So see, these are only red blood cell thrombi. You don't get fibrin here. In this glomerulus, there are no fibrin. All of these are red blood cells thrombi here and here and here. And of course, they do have some platelets, and you see here. And then you have some endothelial swelling here, maybe an early fibrin one here, and so on. So this is, again, classic TMA. Another TMA. Now here you have more, you start to have mesangiolisis. As you see, if you look carefully at this glomerulus, you cannot see the mesangium. This is one also of the remarkable lesions of TMA, that the mesangium starts to be degraded. You lose the mesangium. The term, it's called mesangiolisis. And then later on, this mesangium is replaced by sclerosis. But you lose the mesangium and the capillaries start to dilate markedly because they are not supported or controlled by the mesangium anymore. And you can find here again endothelial swelling and a large fibrin thrombus. Look at this. This was from a lupus patient. It had a large crescent and again fibrin thrombus. You can find crescents in thrombotic microangiopathy, but up to a certain percentage. And here it's very important, a follow-up on what we discussed last time, because TMA is commonly associated with vasculitis. It's very common in small vessel vasculitis to find associated thrombotic microangiopathy. So if you have crescents and you have more than 50% crescents, then this is not thrombotic microangiopathy, even if you see one or two glomeruli with TMA. You have to see what's the dominant lesion. So we accept around up to 20% crescents within the context of thrombotic microangiopathy. If not, then I'll have to consider that this is a vasculitic lesion, and what the main lesion is are the crescents, and then I'm seeing the thrombotic microangiopathy as an association, not as the main lesion. So we can accept crescents in TMA, but up to a small percentage, not a very high percentage of crescents. If the crescents are more, then this is small vessel vasculitis. Any small vessel vasculitis, whether ANCA, whether immune complex mediated, whether lupus, whatever it is, would cause thrombotic microangiopathy with it. And by EM ultrastructurally, you get early duplication of the basement membrane. You see, you have the basement membrane get accumulation of this fluffy material, the ones with the asterisks on it, and all of this fluffy material is in the subendothelial region. This is the capillary lumina full of red blood cells. All of these black structures are the red blood cells. And I want you to see that the red blood cells are actually leaked in the subendothelial space. And this is what we see. This is the endothelial cell. These are the red blood cells. You have red blood cells here in the subendothelial space, and you have what we call this fluffy material accumulated in the subendothelial space. Probably it's some form, it is some form of plasma exudate or something. Again, this is the difference between a lumen, a regular lumen, capillary lumen, and a capillary with thrombotic microangiopathy. This is just to show you what we mean by subendothelial expansion. So you see, this is a normal glomerular basement membrane. You have all the podocytes nice and intact. You have a very nice endothelial cell here, and look here. Then you have all of this expansion, all of this with all this subendothelial space expanded by all of this fluffy material. And look at the red blood cell. This is all what is left of the lumen. Only this area which is surrounding the red blood cell. So this is what we mean by subendothelial accumulation. Then by time, the lesions get to be more subtle or more chronic. We get to see more mesangiolisis, as I'm telling you. Look at the glomerulus, you don't see any mesangium, and look at the loops, at the capillaries. See, they are dilated, and they start to take free form, a change we call them capillary microaneurysms. This is microaneurysmal dilatation of the capillaries due to the mesangiolysis, because we lost the mesangium, and so the capillaries start to dilate. And by time, you start to have glomerular basement membrane duplication. This is not a very chronic change of thrombotic microangiopathy, because actually it starts early on, because this duplication starts early on by the irritation of the material which is deposited in the subendothelial space. But as you can see here, you start to have frequent segmental peripheral duplication of the basement membrane. This is new basement membrane formation, which eventually results either in global or segmental duplication of the glomerular basement membranes. This is again chronic, and by trichrome to show you, do you see the red blood cells, the fragmented red blood cells, and this with this nice stain? And the duplication of the basement membrane in thrombotic microangiopathy is interesting because you get all of these vacuoles, vacuolation actually, and you will read it like this if you're going to read the pathology in a textbook. It's called, it says thick vacuolated basement membrane. You don't see it. You don't see really this thick solid basement membrane, but you get this vacuolation inside the basement membrane. Again, here you get the vacuolated, a lot of vacuolation, a lot of swelling. This is the main lesion in this type of injury. Everything is swollen, a lot of exudation, and a lot of red blood cells. And as I said, by chronic changes, eventually you will get peripheral duplication of the basement membrane. You see, this is the original glomerular basement membrane, and this is the another duplicated, this is the second duplicated layer. This is TMA again, and you see here this one, this is extensive mesangiolysis. We have fibrin thrombi all over this glomerulus, and this is the very acute lesion, and this is the chronic lesion, where you get you get glomerular basement membrane duplication, but you still get this endothelial swelling, and sometimes with mesangial proliferation, as well as some leukocytes. These are the glomerular lesions. What about the vascular lesions? Now, as we said, this is mainly a disease of arterioles, capillaries, and interlobular arteries, because we consider interlobular arteries a direct continuation from the arterioles, or vice versa. So we consider them almost arterioles. So the first thing is that, again, you get endothelial swelling in the arteries. You see that? This is the endothelium, this is the entemal swelling, and you start to have this extensive swelling of the endothelial cells. Look here. Look at this endothelial cells. This is the arteriole, this very small structure, and all of these vacuoles are swollen endothelial cells. All of these white spaces are swollen endothelial cells. You look at these two blood vessels and you don't see any thrombi, no anything pink colored or red color, and you don't see any red blood cells or fragmentation. And again, this is a classic TMA, even without the red blood cells or the thrombosis. Now look here. Here, this is another arteriole with marked endothelial swelling, and you can see the red cell fragmentation. Do you see the red cells actually getting into the wall of the arteriole, the extensive red cell fragmentation infiltrating all through the wall, and early fibrin deposits together with the endothelial swelling? This is pathognomonic of thrombotic microangiopathy. Nothing else causes this extensive red cell fragmentation. This is another arteriole, this time with a large fibrin thrombus and fibrin deposits within the endothelium, and you have red cell fragmentation. Look at this one. This was extensive. You can see this is not a crescent. This is the extensive red cell fragmentation with the endothelial swelling, and you see, you can't see this is what's left of the glomerulus, again, with this extensive congestion. And maybe this was a crescent which completely underwent congestion and transformation with this red cell fragmentation and a huge fibrin thrombus. You cannot see the artery anymore. So thrombotic microangiopathy lesions can be mild and subtle lesions and can be as severe as you can see here. By time, all of this red thrombi and this endothelial swelling is going to change into what we call mucoid degeneration, mucoid entemal degeneration. This is the blood vessel, this is the lumen, and all of this light green material you see here are the myxomatous changes. Look here again, and you get all of these myxomatous changes. What is the result of these myxomatous changes? Look here, and look at this artery. This is an interlobular artery, extensive myxomatous degeneration into the entima, evacuation of myocytes, and this is what is left of the lumen. So you get severe arterial and arteriolar stenosis as a result of this mucoid entemal degeneration. This is directly related to the high serum creatinine which patients present with. So these patients, even though they do have the TMA as an acute lesion and they don't have any interstitial fibrosis or tubular atrophy, actually present with renal failure because of these arterial lesions, because of the affection of the arterioles. And what is worse is that these arterial lesions result in resistant hypertension, and this resistant hypertension worsens the kidney function, and we get into a vicious circle with these patients which do not recover. And some of them complicates by hypertensive encephalopathy. Sometimes some of the larger arteries can also have a thrombus, as you can see here, but this is very, very rare, and this patient had really an extensive thrombotic tendency. As I said, by time, this is what you're going to get. Now, these are the older lesions. See, then you start to get this onion skinning of the arterioles, together with some arterioles still have inflammation and they still have fibrin thrombi. This turn could be completely chronic, where you have only arteriolar halinosis and you have an ischemic shrunken glomerulus. Look at this blood vessel, horrible. This is extensive onion skinning and almost no occlusion left, with very minimal fibrin deposits left. And look at this, another arteriole, again with extensive mucoid degeneration, onion skinning. You have so many layers here and no more lumen to look at. So this is the spectrum mainly of the glomerular acute and chronic, and the vascular acute and chronic changes of thrombotic microangiopathy. The main differential diagnosis of TMA, especially if it's only glomerular involved, if it's only presenting with leukocytes and some endothelial swelling, and you don't have frank thrombi, and you don't have frank arteriolar lesion, is membranoproliferative glomerulonephritis. You get segmental peripheral duplication, you get leukocytes, and especially MPGN early on can present like this. And I once had a case of a 20-year-old female which came as a consultation, and this case was diagnosed as an MPGN, and the girl did not have anything clinically to say that she is MPGN, and she went for some time on immunosuppression, but then her nephrologist was not really convinced when she went to take another opinion, and it was sent for consultation, and actually it was the thrombotic microangiopathy. It was not an MPGN. And the girl was lucky enough that she resolved. We never knew why did she has the TMA, but in all cases, there is a huge difference between a diagnosis of a chronic serious glomerulonephritis like membranoproliferative GN and a thrombotic microangiopathy. How are we going to differentiate? We're going to differentiate by immunohistochemistry. TMA is negative immuno. Any deposits which are going to be there is just non-specific entrapment. And even if it's caused by an autoimmune disease, even if it's lupus, as we discussed in lupus, some lupus patients present only with thrombotic microangiopathy. And again, they are not going to have immune complexes. They might have some segmental immune complexes, which are not going to be diagnostic. But we consider this TMA is from lupus because we know that the patient is lupus. So thrombotic microangiopathy is a light microscopic diagnosis, full stop. By immuno, it's negative, and by electron microscopy, as I showed, it's going to show this subendothelial space. But if it's late enough, then you're going to have a segmental basement membrane duplication. And in transplant, the differential diagnosis, I don't consider this a differential diagnosis. And we're going to discuss this when we come to transplant, that we have transplant glomerulopathy versus chronic TMA. Actually, they are the same entity. They are continuation of the same entity. So as far as we're concerned, in the native, I just want you to know that this is a main differential diagnosis and a main point of, well, how should I say it, a pitfall of diagnosis between MPGN and thrombotic microangiopathy. So this is the pathology. Let's talk about classification and the dilemma we're living in, considering what do we consider thrombotic microangiopathy. Okay, the classification of TMA, or the way we look at TMA, is actually challenging and constantly evolving. Historically, we consider thrombotic microangiopathy as TTP, which is caused by Adams 13 deficiency, HUS, which is hemolytic uremic syndrome, Shigella associated. Anything else, or HUS of any other cause, we consider it a typical HUS. And this is how we used to look, or this is what we knew about thrombotic microangiopathy, to the extent that still now, nephrologists or clinicians refer to thrombotic microangiopathy as TTP/HUS, that the patient had TTP/HUS, not a TMA. And there is a big difference between these two terms. Then when we discovered complement dysregulation, as we discussed in C3 glomerulopathy, we knew that we have some forms of atypical HUS, which could be complement mediated TMA. And then we changed these into atypical HUS also. All the complement mediated TMA then fell into this category of atypical HUS of any other cause. The problem is that this different nomenclature leads to difficult interpretation, and you cornered all the possible causes of thrombotic microangiopathy into three categories. Either it's TTP, either it's Shigella-induced hemolytic uremic syndrome, which is an infection, and anything else, then it's an atypical HUS. Then how are we going to manage or treat our patients? So this changed. And the current approach since 2018 is to look at TMA. Again, as we said, our target now is to try to look at the pathogenesis, to know where is the problem, to know how we can manage the patient. So to look at TMA as either primary TMA, and this primary TMA could be hereditary or acquired, or secondary TMA, and I'm going to say all the secondary causes of TMA, or infection-induced TMA. Again, don't forget infections. I stress on and on and on. Don't forget infections. Don't forget infections in their effect in endothelial insults and in the process of vasculitis. Don't forget infections when you're dealing with your renal patient. So infection-induced TMA is a category on its own. So what we have is either primary TMA, hereditary or acquired, secondary TMA, and infection-induced TMA. Now let me explain these types. So look at this diagram. It's not mine, of course. We have primary TMA, which is hereditary, here in this box on the left. And then we have primary TMA, which is acquired. So this is the upper half. And the lower half, we have on the left secondary TMA, and on the right infection-associated thrombotic microangiopathy. Let's look at them one by one. In primary TMA, or the hereditary type, then these are the ones where we have the TTP with Adams T13 mutation, and where we have the atypical HUS with complement gene mutation, and where we have the cobalamin deficiency mediated thrombotic microangiopathy, and when we have the DGKE TMA, which is one of the rarest cause, and this is usually presents in children. So if I excluded the rare one, and the cobalamin deficiency is rare also, so a primary TMA, the hereditary one, then we will be mainly TTP with Adams 13 mutation, or a typical HUS with complement gene mutation. So what do we mean by primary TMA acquired? The acquired means that I don't have a mutation. It means that I developed autoantibodies against these genes. And this also is the same. It's a typical HUS with factor H autoantibodies, so also a typical hemolytic uremic syndrome related to complement, or TTP with Adams 13 autoantibody. So primary thrombotic microangiopathy is either that I have a mutation in the gene, so I have a TTP with Adams 13 mutation, this is hereditary, or I have an autoantibody against the Adams 13, then I would consider this primary but acquired. It's not hereditary. Or the second entity is a typical HUS where I have a complement gene mutation, then this is primary hereditary. Or I developed an autoantibody against factor H, then this is acquired. And then I have two other hereditary lesions, which are much less frequent, which is the cobalamin C deficiency mediated thrombotic microangiopathy and the DGKE. Only these entities, I consider them primary thrombotic microangiopathy. What about the rest? Then we have infection-induced thrombotic microangiopathy. We have, of course, the known infection in which is our typical hemolytic uremic syndrome or salmonella. But we also have other infections, pneumococci, HIV, and a long list, believe me, a very long list of infections which can cause also thrombotic microangiopathy. So not every patient of yours, which is going to come presenting with a fever and a possible infection, and then he presents with a thrombotic microangiopathy in his kidney, and because he did not have a history of diarrhea, you're not going to consider that this is infection-induced thrombotic microangiopathy, or what we call hemolytic uremic syndrome. So infection-induced or infection-associated thrombotic microangiopathy is not only limited to the typical diarrhea or D+ hemolytic uremic syndrome we know of, okay? So you need, yes, pneumococci cause it, HIV cause it, you can have it as a complication of staph, and so on. Then the secondary thrombotic microangiopathies. Now, this is a large group. And within this group, we have large subgroups. And let's talk about them. We have the ones we know very well, we're familiar with, the thrombotic microangiopathy with autoimmune conditions, like lupus, like scleroderma, like antiphospholipid syndrome, okay? So these are we all know of this. So I cannot call a TMA in a scleroderma crisis or an antiphospholipid syndrome. Don't come and tell me the patient has TTP/HUS. This doesn't make sense. This patient has a thrombotic microangiopathy related to his autoimmune condition. Then we have the drug-induced thrombotic microangiopathy. Now, this is also very important because we have, again, a long list of drugs. Don't forget that contraceptive pills cause thrombotic microangiopathy. These are very common drugs. And we have other drugs which cause interferon causes drug-induced thrombotic microangiopathy. And there are other drugs. And of course, most of the a good percentage of the chemotherapy used drugs also causes drug-induced thrombotic microangiopathy. So we have drug-induced. Then we have thrombotic microangiopathy after bone marrow transplant, graft versus host disease. This is not common. Again, to common situations, pregnancy-associated thrombotic microangiopathy / HELP syndrome. So we also, all of us see these ones. Then we have thrombotic microangiopathy with severe hypertension. Yes, if a patient has a severe, as we discussed last time, if we have accelerated phase hypertension, if we have severe hypertension or uncontrolled hypertension or recently diagnosed very high hypertension, yes, these patients develop thrombotic microangiopathy with no other underlying cause. That does not mean that we don't have to investigate for the other causes, as I'm going to show you at the end. But know that this is a separate entity. It's a separate cause and etiology. Another important separate entity, and we've discussed it as well, is thrombotic microangiopathy with glomerular diseases. And we've discussed it within last time also, that as the glomerular diseases develops towards chronic phases and towards end-stage renal disease, there is tendency to develop thrombotic microangiopathy. So this is a separate entity on its own. So when you have a patient with an FSGS who's mainly going stable, or with membranous, which is more common, who's going stable, as I showed you, exactly as I showed you in the case, and this patient is going stable and suddenly things deteriorate, and then you have thrombotic microangiopathy in his biopsy, this TMA is related to his membranous nephropathy. It doesn't mean that the patient all of a sudden developed another form of disease. And as I said, we see it commonly in ANCA vasculitis. So we get it in ANCA-associated vasculitis. You can see it in IgA nephropathy. You see it in membranous nephropathy. You see it in FSGS. And you will see it in membranoproliferative GN and C3 glomerulonephritis as an examples. But these are the common glomerulonephritis. We actually do see thrombotic microangiopathy with them. Quite common in AAV, in ANCA-associated vasculitis. That's why I said you need to be very careful with this diagnosis if you're doubting that the patient has vasculitis or ANCA-associated. And then, of course, malignancy-associated thrombotic microangiopathy, and I'm going to cover it later on. But the most important circle in this slide is this one. That in spite of all of this, you have to accept and know that the fact we are living in, that up to 50% of your patients, you're not going to know what caused the thrombotic microangiopathy, and that we do have unexplained TMA. So you can do all of these tests, or you cannot identify an underlying cause, but your patient has a TMA, and then you will have to deal with it as it is, because we do have up to 50%, and it's not only us here. This is, you ask anyone, even those in Mayo Clinic who do the most sophisticated tests, and then they're going to tell you, yes, almost in half of our patients, we don't know why they have thrombotic microangiopathy. We cannot identify the cause. And what also I want you to know is that although we can classify them this way and into these 4 categories, however, you have to know that we have some overlap. So if we have a de novo thrombotic microangiopathy after solid organ transplant, after renal transplant, for example, then I need to consider recurrence, and I need to consider that maybe this patient has a hereditary thrombotic microangiopathy. We also need to know that although we have infection-associated thrombotic microangiopathy, that infections are going to actually trigger a hereditary form of primary thrombotic microangiopathy. I know it's a bit complicated and there are a lot of causes in it, but I hope that it's clear how we look at thrombotic microangiopathy now and how we all should look at this pattern of disease, and that we don't limit it into TTP or HUS, and that we have to stop, we have to drop this terminology and correct our terminology, because this is the first step which is going to correct the way we think, the way we approach our patients, and the way we're going to manage them. Whatever it is out of all of this, the pathogenesis is the same. Yes. لا أنا مستمعك يا دكتور حسين.
I want to add one statement. سامعني كده؟
اتفضل.
To add to the complexity, even hypertension may aggravate and precipitate the atypical form of hemolytic uremic syndrome. So sometimes we say it is secondary to hypertension, and it is again hypertension stimulates and expresses the genetic mutation. And this is the same with postpartum, because the French group found large proportion of ladies with genetic mutation, and the diagnosis was postpartum. So it is really a dilemma.
Yes, and with the glomerulonephritis.
Yes.
Most of these patients are already hypertensive. Yes. Definitely. So I agree with you 100%. And this is why I said it is complicated.
Yes.
And that we have to consider that it can be multifactorial, and that you have stimuli which is going to aggravate the situation. What we care about is the primary ones, because these are the ones which are recurrent post-transplant, and these are the ones most problematic in their management, actually, apart of course from the pregnancy, if the patient got into HELP and so on. But these are the ones we need to test for if we're considering the patient for transplant. The other ones, I don't think that there is anything we can do about it. It's still a grave disease with a poor prognosis.
Another important point is the age, because in pediatric, we don't expect to find thrombotic microangiopathy. So it is not the Adams 13 pathway in children. It is a typical hemolytic uremic syndrome rather than a thrombotic thrombocytopenic burden.
Or Shigella induced.
Yes.
I mean,
yes.
most of the children we see from Yemen are probably infection associated, for
yes.
example. So you have to consider, where are the patients coming from? What is their background and so on? They probably have some form of endemic or an epidemic of Shigella, because we do see a lot of HUS from them. And as I said, the pathogenesis of whatever the cause is the same. The pathogenesis is basically a direct endothelial damage, which is going to cause swelling of endothelial cells, detachment of the endothelial cells, platelets, and intravascular platelet thrombosis. And this process actually corresponds to all what we see in the histology or in the pathology. Just going to remind you with the complement dysregulation and disease, we've already discussed this, and we've discussed that in a typical HUS, this is what you get. You get a decreased regulation, and you get loss of function factor H, factor I, and you get on factor B, C3, and you get the dysregulation on cell surface activation of the C5 convertase. So you get endothelial injury, and that this is distinct from what we call C3 glomerulopathy, because this is not, although they are a complement regulator disease, you don't get C3 deposits in the glomerular, because I get asked this question a lot. So we have thrombotic microangiopathy. Can we have the C3 stain to know if this is a typical HUS? No, we cannot, because this is an endothelial injury. You don't get C3 deposits in the glomerular. The second type I want to highlight is the transplant, the thrombotic microangiopathy, which occurs in transplant. Now, the first, when we got introduced acute thrombotic microangiopathy in grafts or in transplantation, it was mainly drug-induced. But then, since 2014, it was also included as one of the main features of active antibody or acute antibody-mediated rejection. And hence, in transplant, the differential diagnosis usually of thrombotic microangiopathy is that we consider what's common first. So the commonest things are, it's an ABMR, it's drug-induced, it's recurrent disease. If it's antibodies, we can exclude it, and this is one of the more confident diagnoses of TMA cause-wise, because we simply look for antibodies. And if the patient doesn't have any form of antibodies, and if he also happens to have high drug levels, then this is probably drug-induced and not induced by the rejection. So at least in transplants, we get some more insight into the cause of TMA. And then finally, TMA and malignancy. And I've also discussed this in monoclonal gammopathy. I'm just recapping with you since we're considering thrombotic microangiopathy. And now the relationship between TMA and malignancy is not new. This is a very old relationship. We've always known that solid organ malignancies, especially mucinous carcinomas, causes thrombotic microangiopathy. So cancer colon is one of the main culprits of causes of thrombotic microangiopathy. However, as I said, as I've mentioned before, a couple of years ago, the Mayo Clinic report came out that you can also have a thrombotic microangiopathy with a monoclonal gammopathy. So if you have an elderly patient or a patient over 50 years old, and you get an unexplained thrombotic microangiopathy, then you need to consider malignancy with all its forms, including monoclonal gammopathies, meaning lymphomas and multiple myelomas, and so on. Okay, we cannot really tell you the diagnosis, we cannot tell you the cause behind the thrombotic microangiopathy, and as I said, this is only a pathological description, and I know that this is disappointing, but what we can tell you is the prognosis. We can tell you how this kidney is going to perform. So the prognosis depends actually on the degree of histological damage rather than the initial clinical severity. So you do need the biopsy, even if you know 100% sure clinically that this is thrombotic microangiopathy, because you need to know how much damage you have in the kidneys, because this is the predictor of long-term prognosis. We have three main patterns that correlate with long-term prognosis. If we have the involvement only in the glomeruli, as we usually see in young children, and these ones have to have good prognosis. If we have dominating arterial compartment, and usually you see this in older children and adults, and this has poor prognosis. And adults with both glomerular and vascular involvement also have poor prognosis. So you see the bottom line that once the arterioles and the arteries are involved, you get into a poor prognosis. If it's glomerular only, then you do have a good prognosis. Or if your vascular involvement is not that severe, if you only have few arterioles which are blocked by some fibrin thrombi and you still don't have chronic changes, then you're also looking for a good prognosis. The severity, cortical necrosis is very important. When you have cortical necrosis, this is a severe insult, then you're looking at a poor prognosis. If the TMA involves more than 50% of glomeruli at time of presentation, معناها إيه دي؟ معناها that we can see thrombotic microangiopathy only in less than 50% of glomeruli? Yes, you can have thrombotic microangiopathy in one glomerulus, in a single glomerulus. And still, this establishes the diagnosis. So a single glomerulus which have TMA changes establishes the diagnosis. So if we have more than 50%, meaning that it's diffuse, this is again a poor prognosis. And of course, the stage you biopsy the patient in, the more we detect the changes early, the more chance we have a better chance with this patient. So this is, again, as I said, if you have a glomerular only, it's better than when you have this vascular involvement and you have cortical necrosis. This is a very poor prognosis. Look at this. This is a horrible kidney. This is a kidney which you're never going to recover. You can hardly see the glomeruli from the extent. This is glomeruli, by the way. You have 1, 2, 3, and you can see the extent of red cell fragmentation, the endothelial swelling. You have another glomerulus here, which is okay. You have the extensive red cell fragmentation into the interstitium and the tubular compartment. Look at this arteriole and the extensive, all of this is going, the extensive, again, red cell fragmentation, all of this is going to be occluded later on by sclerosis. This is a very poor prognosis for this kidney. So my take-home message is that thrombotic microangiopathy is a descriptive and a non-specific morphological term. It's not a disease. The pathologist cannot reliably identify the underlying causative agent or event, but the report suggests the features which can suggest the underlying etiology. As we said, glomerular only versus arterial only versus the age and so on. So it is very important to identify the underlying cause of the histologically observed thrombotic microangiopathy, as some of them could be managed, and you can eventually save your patient and save their kidneys. TMA is, you don't only have these two causes. TMA is not hemolytic uremic syndrome and TTP. Well, thank you.
Thank you very much, Professor Wesam, for this excellent. And although it is a dilemma, but I think now it is very clear for us that the role of pathology is to establish diagnosis and to give us a prognostic tool for the prognosis. And
Exactly.
I agree with you 100%. We have a case, current case admitted to the center with thrombotic microangiopathy, but the morphology is very chronic. This is why we don't give immune suppressive drug for this patient. So pathology is essential to guide us even in the treatment. لو أي حد بقى عنده أسئلة أو حاجة ممكن
شوف لو في أسئلة.
دكتور هاني منصور افتح عليها معتصم.
Yes, thank you, Dr. Wesam. I want to ask about if there is any activity between the overactivity of C3 convertase or C5 convertase overactivity.
دكتور وسام. دكتور وسام قفلت على نفسها.
لا اعملي ميوت. ايوه لخبط قال لي نحط عني ميوت.
طيب اتفضلي.
You mean that if you come to detect it, that you find overactivity in atypical hemolytic uremic syndrome? I don't think that they can measure overactivity. I think they can only measure if you can have autoantibodies or not.
And I think سؤالك يا دكتور هاني, I think it's valid. It is valid in C3 glomerulopathy. لكن زي ما الدكتوره وسام وضحت تماما ان في ثرومبوتيك مايكروانجيوباثي ما فيش C3 ديبوزيشن موجود في التيشوز, لان في عندي سيرفيس افكشن وليكويد افكشن, الاثنين بيبقوا مضروبين في C3 glomerulopathy, لكن هنا مش هتلاقي ديبوزيشن في التيشوز.
تمام, شكرا.
انا اعتقد ان هي كانت واضحه جدا يا دكتور وسام. هي المالجنسي اسوسييتد ثرومبوتيك مايكروانجيوباثي بتخلينا برضو ما بنعملش بلازما اكسشينج, لان احنا ما بنبقاش مأملين فيه. لكن لو انا حاطط اوتو اميون, حاطط تي تي بي اللي هو الادمز 13, دولت البلازما اكسشينج دورهم واضح جدا فيهم. للاسف لو انا بقول اتيبيكال هيموليتيك ريميك سندروم واكسكلود الانفكشن والكلام ده, احنا ما عندناش اكلوزيماب تو تارجت السندروم ده, وعشان كده بيبقى في مشكله في الدول اللي عندها ليميتد ريسورسز, واعتقد برضه في الدول الغنيه ان هو يوفروا اكلوزيماب للبيشنتس بتوع الاتيبيكال هيموليتيك ريميك سندروم.
واعتقد ان كمان they discovered that there is a sector of these patients with atypical hemolytic uremic syndrome that they do not respond برضه to ocrelizumab.
بالظبط وبيقعدوا يحللوا بقى يقولوا ده ممكن يبقى ان هو ليت وكلام زي كده، لكن في النهايه ما هوش هو الماجيك بولت اللي بيحل المشكله. عشان كده النقطه المهمه كمان في لما العيان بيخش في رينال فيلير وبيجي ترانسبلانتيشن، لو احنا مش متاكدين قوي من الدياجنوز، يبقى نبعد تماما عن اللايف ريليتد دونر ترانسبلانتيشن. بنحط كرايتيريا وبنشوف الاوكرنس والتايم ما بين الدياجنوزس والاند ستيج والايج اوف ذا بيشنت، وفي النهايه لو بنأكسبت unrelated donor kidney transplantation rather than related، لان احنا بنخاف يكون الدونر لو related carrying heterozygous للميوتيشن او حاجه زي كده، فممكن يبقى مع الاستريس بتاع الجراحه ينديوس ثرومبوتيك مايكروانجيوباثي للدونر افتر كدني دونيشن. فده احد الحاجات اللي برضو الواحد بياخد باله منها.
ده حقيقي. فايس فيرسا كمان بلاش، عشان I get this a lot، ان لما يبقى في عيان with all features of glomerulonephritis وهو عنده thrombotic microangiopathy، ما تحكموش على العيان ان ساعات كتير قوي nephrologist turn them down، لا مش هتنفع to transplant because it's going to recur. No, either you investigate this patient very properly or know that you can have other causes of thrombotic microangiopathy which are mainly secondary، وان العيانين دول they are not going to have recurrent thrombotic microangiopathy in their grafts.
ما انا اعتقد دي من اهم من انت حضرتك قلت حاجات كتيره النهارده، لكن اعتقد دي من النقاط المهمه جدا. مش كل ثرومبوتيك مايكروانجيوباثي كومبوننت يخليني اسيب المين ستريم، وخاصه في بلد زينا ما عندناش الجينيتك ميوتيشن تيستنج، وحتى لو اتوفر الفاكتور اتش ولا الفاكتور اي مش هنعمل بقيه الميوتيشنز اللي ملهاش اول من اخر. فاذا كان الاتيولوجي واضح ممبرنس مثلا وده اكامبانينج، فهو ات ذا اند اوف ذا داي ده مجرد اندكس للاندوثيليال دامج.
فده يعني خلاص هو this is
is membranous yes او glomerulonephritis، واركز في المين etiology rather than accompanying thrombotic microangiopathy.
دكتوره سلوى بتسال على الحاله بتاعتي what is the cause of TMA in a 12-year child. I don't know. As we said, it could have been any one of these differential diagnoses.
مش حاله المالجنسي.
اول حاله اللي انا ابتديت بيها ايوه حاله
المالجنسي ممكن يكون دراجز، لان في دراجز
ممكن يبقى دراجز، ممكن يبقى من المالجنسي من
لكن انا
عنده ممكن يبقى من الانفكشن.
انا هسيب الكلام ده، مش هركز في ثرومبوتيك مايكروانجيوباثي هنا، انا هركز في المالجنسي نفسه.
طبعا
لان ما فيش دور حتى البلازما اكسشينج هنا في السيتويشن ده، ولا الثرومبوتيك افتر بومارو في دور فيبقى ابقى انا عارف بس الايتيولوجي واتعامل معاه.
هي الفكره في الحاله ان هي it's a very good demonstration that you can have a thrombotic microangiopathy and you don't know why this patient developed thrombotic microangiopathy. انه ممكن يكون عندك a long list of suspicions and you don't know. فهي مش هياش directly affecting. النفروتيك سندروم اللي كان الهيستوري اللي كان اوف نفروتيك سندروم ده كان كده unreliable history، بس هي الفكره ان الانفورميشن دي كانت المين درايف بيهايند ذا بايوبسي.
تمام. الدكتور ابراهيم السيد.
شكرا لحضرتك يا فندم. هو والله انا عندي سؤال، هو ليه يعني كانسر كولون في طفل 12 سنه ادم كارسينوما؟ وده مثلا
سؤال غريب قوي يا دكتور ابراهيم. ما ممكن الطفل يجي له اي مالجنسي يعني؟
لا هو عامه الكارسينوماز لا هو عامه الكارسينوماز طبعا are much more common over 40 وده اللي احنا طول عمرنا نعرفه.
ده بقيه الجمله اللي كنت هقولها. انه يس فيه ما بقول الايج، يعني لما بنقول الميلومه ما كنا بندرسها في الكليه فوق الايج فوق 70 سنه، احنا بنشوف ثلاثينات واربعينات واصغر عندهم ميلوما كدني
24 و27.
فيبقى اذا
المالجنسيز اتغير خالص، ما بقاش عندنا specific entity يعني related to age.
وما بقى عند الايج الايج بحترم الكلام اللي مكتوب في الكتب لان ده الموست كومن، لكن it is not a guarantee ان انا في اي ايج الاقي ليجنز.
ده حقيقي.
تمام. طب لو جه في سن مثلا صغير زي كده ممكن يستدعي ان انا اعمل جينيتك تيست مثلا زي اللينش والحاجات دي؟ ايفن اللينش كان مثلا اقل من 40، انما دلوقتي انت بتاخدنا لسيكتور احنا مش اور بيه، اللي هو او انا مش اور بيه، اللي هو الكانسر كولون وهاو تو بروسيد.
اعتقد اللي يرد على الكلام ده الجماعه المتخصصين في الاونكولوجي او بتوع الجاسترونترولوجي بيبقى اوير بالكلام ده بيعملوا ايه وما بيعملوش ايه، ودي اوتسايد ذا سكوب اوف ذا برزنتيشن. لكن لما يكون عندي كانسر كولون وجايب ثرومبوتيك مايكروانجيوباثي، احنا دلوقتي واخدين الثرومبوتيك مايكروانجيوباثي، هعمل له ايه؟ هغمض عيني على الثرومبوتيك مايكروانجيوباثي وهركز في الكانسر كله اشوف عالجه ازاي. مش هروح ادي له ايمين سبريشن ولا بلازما اكسشينج.
بالظبط. الاكيد سابريتيف TIN is not a clue for drug induced thrombotic microangiopathy. It would be a clue for an infection induced thrombotic microangiopathy. ده سؤال برضه.
ده ما كان سؤال الدكتوره سلوى برضه كان حطاه في الاول، اللي هي السابريتيف تيوبل انترستيشن نفرايتس في الكيس.
أيوة.
فممكن يبقى ميكسد انفكشن مع مالجنسي مع دراجز، فهو كوكتيل ومفيش حاجه ممسوكه 100%. في اي حد عاوز يسال حاجه ثانيه؟ دكتور طارق؟
لا تمام يا باشا.
بتهيألي انها يعني دكتوره وسام احنا مش عارف نكتفي النهارده كده ونبدا التوب انترستيشن نفرايتس مع اول اليوم اللي جاي يبقى افضل، عشان لان كده لا بس انا عاوز فعلا احييكي جامد جدا دكتوره وسام. من امتع الباثولوجي سيشنز اللي سمعتها للثرومبوتيك مايكروانجيوباثي. very clear. thank you very much.
الحمد لله.
وان شاء الله نلقاكم على خير ان شاء الله بكره الساعه 9 مع الدكتور محمد عبد الجواد اليورين اناليسيس، وبعدين ان شاء الله مع الدكتور وسام الاسبوع الجاي في يوم الثلاث باذن الله. هنبقى برضه 9 ولا 9:30 يا دكتور وسام؟
9:30.
9:30 خلاص. يبقى الثلاث الجاي 9:30 ان شاء الله مع الدكتور وسام. احنا يعني مش عارفين نشكرك ازاي، لكن احنا مكملين مع حضرتك لانه علم فعلا مفيد جدا جدا جدا. شكرا جزيلا.
العفو.
وتصبحوا جميعا على خير، والسلام عليكم ورحمه الله وبركاته.
شكرا دكتور وسام.
العفو دكتور طارق. ميرسي.
شكرين. السلام عليكم.